Welcome to Baxter's Connected Care webinar. I'm Bob Williamson, a medical science liaison within medical affairs at Baxter. I'll be your facilitator for today's educational program titled Validation of BMAT Scores Between Clinical Observation and the EMR. Couple housekeeping slides. This webinar is sponsored by Baxter as a learning opportunity and activity. The presentation content has been fully developed by our presenters. All lines during this presentation will be muted. At the conclusion of today's presentation, questions will be answered, and you can enter those questions simply by putting them in the chat function in Teams. Any questions that are specific to Baxter's products should be directed to our medical information team at the website and email address on your screen. This webinar is being recorded for educational purposes. A link to access the recordings will be available approximately 1 week from today's presentations. For those that are registered, you'll receive that link. Today's webinar is very straightforward. We have three learning objectives. One, how BMAT observations are documented within the MedStar Health EMR. Two, the interdisciplinary approach MedStar Health has used to validate these findings. And three, how those results impact clinical practice, safe patient handling and mobilization equipment decisions, caregiver education, and impact on patient length of stay. Before we get into today's content, I would like to take the opportunity to present our three outstanding presenters that are leading today's presentation for you. First, Teresa Boynton is an independent consultant and a subject matter expert on the complications of immobility. She assists healthcare professionals build sustainable, safe patient handling and mobility initiatives that embody the use of a standardized mobility assessment. Teresa worked for Banner Health implementing standardized safe patient handling and fall prevention programs. This is when she began the journey to develop a standardized mobility assessment that would ultimately be known as the Bedside Mobility Assessment Tool, or as most of us know it, the BMAT. After the initial launch, and with an additional 5 years of caregiver feedback, she developed the BMAT 2.0. In 2020, Teresa was recognized for her efforts and received the Innovative Award from the National Board of Certification in Occupational Therapy. Teresa is a member of the Association of Safe Patient Handling Professionals and is actively engaged in the certification exam and renewal committee activities. Our second presenter today is Donna Walters. She's a System Director for Nursing Practice Innovation for MedStar Health. In this role, she provides leadership for implementing sustainability of evidence-based nursing practice and standards of care that support the MedStar Health nursing professional practice. Donna has led the Safe Patient Handling and Mobility initiatives at MedStar since 2017. She began her career at MedStar as an emergency department nurse at MedStar Georgetown University Hospital, where she continues to practice. Donna received her Doctorate of Nursing Practice and Master's of Business Administration in Healthcare Leadership from the Grand Canyon University. Additionally, Donna is a member of the American Organization of Nursing Leadership, the Emergency Nurses Association, and Sigma Theta Tau International. Our last speaker of today is Corey Burge. Corey serves as the Director of Nursing Practice Innovation at MedStar Montgomery Medical Center. In this capacity, he supports their Magnet program and nursing practice initiatives, both locally and across all of MedStar Health's system. With a background spanning various clinical and administrative roles within MedStar Health since 2017, Corey has demonstrated a passion for advancing nursing practice through shared governance and evidence-based practice. He holds a Bachelor of Science in Nursing and a Doctor of Nursing Practice in Nurse Executive Leadership from the University of Tennessee, Knoxville College of Nursing. Corey is certified in progressive care and evidence-based practice. Additionally, he holds a Lean Six Sigma Green Belt in healthcare. As you can see, we truly have an expert panel with us today. What I'd like to do at this time is turn this over to my colleague and friend, Teresa Boyden, who will introduce today's topic and get us started down this journey. Teresa?
Thanks, Bob. So why the BMAT? Back in 2003, when I was put in charge of the SPHM programs, initially for 11 hospitals, it was apparent that caregivers, especially nursing aides and RNs, were being injured using outdated manual handling and mobility techniques. SPHM equipment was not being used consistently. There was no established standard of care around safe patient handling and mobility practices. Many RNs were unwilling to take responsibility for their role in supporting SPHM practices and the use of lifts. Falls were an issue. Too many assisted falls or controlled descents resulted in caregiver injuries. Too many falls were associated with a lack of awareness of a patient's current or real-time mobility status and SPHM needs. Too many nurses were not taking action or using SPHM interventions based on the fall risk assessments they'd completed with their patients. There was a lack of caution when mobilizing patients diagnosed with orthostatic hypotension or prone to syncopal events. In ICUs, there were too many pressure injuries associated with non-standardized care. Some nurses were using the ceiling-mounted lifts and repositioning sheets to boost and turn ICU patients. Others weren't. There was a failure to consistently mobilize every patient early and often, including bariatric patients. Often caregivers assumed bariatric patients were independent. Practices were either too restrictive and often unsafe for both the patient and the caregiver. The team identified the need for department-specific SPHM equipment. There was also the need for improved awareness and ability to adjust the treatment plan, knowing that a patient's status can change during a shift, and document changes in the EMR and communicate those changes to all staff. There was a lack of awareness or failure to consider how complications of immobility and the negative effects of bed rest impact outcomes and discharge planning needed to be addressed by the multidisciplinary team. Overall, the team identified a need to standardize and provide evidence-based best practice for every patient, ensure that every unit had appropriate unit-specific SPHM equipment, right types and amount of equipment based on BMAT mobility levels found on each unit. In other words, that unit-specific SPHM practices were implemented, the EH and the EMR was improved. Communication tools identifying each patient's mobility status and SPHM needs were posted both outside and inside each patient's room and were updated as needed. Next slide. Why an assessment? While screening and assessment are connected, each has characteristics that separate it from the other. There are critical distinctions. A screening is done to determine if a particular issue exists that warrants a full assessment. The outcome is normally a simple yes or no, with no intervention or treatment recommended based on positive findings. If a screening indicates positive findings, instructions typically include complete and in-depth assessment. An assessment is a process of defining the nature of that problem and developing specific treatment or intervention recommendations focused on addressing the problem or diagnosis. In other words, taking action based on how the patient presents in the moment. In the case of mobility-related challenges, the treatment or intervention may include use of specific SPHM equipment following manufacturer's guidelines and set patient criteria. SPHM equipment may be used to test a patient's current status. For example, using a powered sit-to-stand lift to determine if they can tolerate standing for up to a minute. SPHM equipment may be used to complete a care task. For example, the patient scored a BMAT mobility level 4 in the morning, but late afternoon, they're mobility level 3, and caregivers will now use a non-powered stand aid to complete a bed-to-toilet transfer. Or SPHM equipment may be used to help the patient progress and strengthen. For example, after dinner, the RN decides to hook a mobility level 4 patient up to the overhead track and allow them to walk to complete 600 steps. In other words, complete one of the mobility events or sessions recommended for that patient. In order to choose and use the most appropriate SPHM equipment based on each patient's real-time BMAT level and SPHM needs, the multidisciplinary team needs to consider the patient's comprehensive physical assessment, including their weight-bearing status, primary diagnosis and comorbidities, orthostatic hypotension status, fall risk, pre-admit status, and discharge goals. When implementing the BMAT, nurse leaders recognize they need to adhere to their practice guidelines, which includes providing a safe and effective care environment for every patient on every unit. This includes the RN's responsibility for patient mobility, safe use of equipment, recognizing trends and changes in their patient's condition, and intervening as needed. Nurse leaders also recognize that it's the RN who is responsible for supervising nursing aides, delegating tasks to staff they are supervising, and ultimately it's the RN who bears liability for providing safe and effective care for each patient based on their comprehensive assessment. It takes a multidisciplinary team, but especially in acute care settings, nursing takes the lead in incorporating the BMAT and SPHM practices as part of their comprehensive assessment. Next, I'm going to turn the webinar over to Donna and Corey.
Hi, good afternoon or good morning, depending on where you're joining us from today. Both Donna and I are truly honored and excited to present MedStar Health's Safe Patient Handling Journey, specifically around our system-wide adoption of the Bedside Mobility Assessment Tool and our continuous quality improvement efforts to validate its use across our health system. I do want to note today the work we'll be sharing reflects the dedication and collaboration of countless clinicians and clinical leaders through our interdisciplinary shared governance structure here at MedStar Health. A special thank you to Baxter, Bob, and Teresa for inviting us to be a part of today's discussion. And I do want to really briefly kind of go off script here and kind of connect everyone, just as I'm sitting here, both, and I'm sure Donna reflects on this as well, we built our doctoral work on the BMAT. So, I really just kind of think back to the quote by Sir Isaac Newton, if I have seen further, it's by standing on the shoulders of giants. So the work we're presenting today really does connect with, just kind of reflecting on the countless folks that make this possible. Next slide, please. Oh, we've got the agenda. That's good, Bob. So today we'll walk through BMAT integration across MedStar Health's acute care sites through the lens of the MedStar Health evidence-based practice cycle. We'll discuss lessons learned during our implementation, highlight our ongoing continuous process improvement efforts, and share insights and data from our validation work through clinical observations. Finally, we'll talk about where these data are leading us, outline our next steps, and leave time at the end for your questions. Next slide. To give context to our work, let me first introduce MedStar Health. MedStar Health is the leading nonprofit regional healthcare system in Maryland and Washington, D.C. Our network includes 9 acute care hospitals, 2 inpatient rehabilitation centers, and a wide range of services, including urgent care and ambulatory surgery centers. We have a strong graduate medical education program and are proud to serve as a clinical partner for Georgetown University. Additionally, 2 of our hospitals are Pathway to Excellence designated, and 5 and counting hospitals have achieved magnet status, reflecting our commitment to nursing excellence across the organization. Next slide. So today we're focusing, of course, on our Safe Patient Handling and Mobility program. The why at the heart of this program is to protect both our associates and patients from injury. A key component of our multi-year journey has been the adoption of the Bedside Mobility Assessment Tool. And one of our standout outcomes has been a significant reduction in safe patient handling related injuries, underscoring our program's impact. Next slide. Next slide. MedStar Health's Safe Patient Handling and Mobility journey began in 2016 with the formation of a system-wide Safe Patient Handling and Mobility Committee. The initial focus was on assessing safe patient handling practices across the system and defining the program's scope. In 2020, we launched a dedicated BMAT work group to mitigate the risk of immobility, such as hospital-acquired pressure injuries, venous thromboembolisms, hospital-acquired functional decline, and increased length of stay. The work group also focused on enhancing our safe patient handling practices across the system, and another goal was to align with the American Nurses Association Safe Patient Handling and Mobility Standards. 2 evidence-based practice pilots were conducted to evaluate BMAT adoption into clinical practice, focusing on increasing safe, nurse-led mobility targeted to impact fall rates and length of stay on pilot units. By 2022, we standardized equipment system-wide and completed in-room lift installations. We integrated BMAT into the electronic medical record and developed and rolled out educational resources on our e-learning platform. In early 2023, BMAT was implemented across all acute care hospitals in our system. Throughout this journey, COVID-19 required us to pivot and adapt while implementing the system-wide change and, of course, lengthening our implementation timeline a few times. Next slide. So I thought we would examine BMAT implementation through the lens of MedStar Health's evidence-based practice cycle. To start, we connected with the evidence, evaluating the impact of immobility on multiple clinical factors, looking at mobility assessment tools that existed, and evaluating safe patient handling programs in the literature, ultimately choosing to integrate BMAT into our clinical practice guidelines. We partnered with clinical informatics to build workflows in our electronic medical record where staff now complete BMAT documentation daily. The electronic medical record form used by registered nurses was also designed to provide just-in-time resources to support staff through assessment, patient goals, and equipment use. Next slide. Next slide. Our Product Evaluation and Standardization Council at the system level is the next stage in the EBP cycle. We evaluated and purchased standardized equipment across the health system to support BMAT-guided interventions for safe patient handling. A challenge here we faced that we'll connect with at the end as well was around reusable slings and harnesses. We were required to transition to single-use products due to loss with processing with a laundry partner. And we'll discuss further implementation challenges in a moment. Next slide. Our nursing professional development team worked with the BMAT work group to develop an online educational module on our e-learning platform. 2 versions were created for licensed and unlicensed staff, guiding staff through the risk of immobility on patient care and outcomes, and how to perform BMAT assessment for licensed staff, and the use of appropriate lift equipment selection based on the patient's level of mobility. Baxter Hillrom resources were incorporated along with our just-in-time educational materials for bedside use. An additional challenge here to note was creating scenario-based competency within this e-learning form due to the very limited hands-on education we were doing during the pandemic. Next slide. So when it comes to entity implementation, before we went live system-wide, BMAT, as I've alluded to, was tested on 2 pilot units. We included the same educational modules, educational or electronic health record tools and resources that would be a part of the system-wide rollout. These 2 pilots were conducted independently, focusing on fall rates and length of stay. Based on these results, BMAT was launched system-wide in January of 2023. Next slide. Donna will go over our safe patient handling and mobility structure, including our system-level committee's role in monitoring BMAT use in a moment. She'll also discuss our audit and validation tools in more detail. But first, I would like to highlight some of the key lessons learned. Next slide. And next slide. It's important to note that each site, from acute care to rehab to perinatal areas, has very unique patient populations that required local adaptations to meet their needs, including lift equipment selection. We're also mindful that adding BMAT as a daily documentation requirement certainly does add to task overload for clinicians. A key challenge we continue to address is perceived time constraints related to retrieving and setting up equipment. We found that linking the tool both to the staff member's personal injury prevention and to the risks of immobility on patient outcomes has been helpful in shifting mindsets and improving adoption. Of course, we do have to note national workforce shortages and fundamental changes in models of care, particularly in the field of nursing, remain barriers to sustained use and education for safe patient handling practices. Additionally, we face challenges with reusable slings, as I've mentioned, including loss, and have had to pivot to disposable slings with supply chain partners. Really supporting the system-wide rollout was leadership buy-in and alignment with our HRO principles, including resilience, deference to expertise, and sensitivity to operations, have been critical in navigating each one of these challenges and sustaining success. With that, I'll hand it over to Donna to discuss our committee structure, audit processes, and ongoing efforts.
Thanks, Corey. Now let's talk about how the organization went about validating the BMAT tool. Not that after Teresa had done such an excellent job in the initial rollout of BMAT, we were really not validating BMAT as a tool, but validating that our staff was using it properly. The system level BMAT is a shared governance committee, as Corey had mentioned. It is developed by, made up of nursing, occupational health and safety, physical and rehab medicine. Each local entity has their own safe patient handling committee, sometimes combined with their falls. We at a system level, we have a monthly cadence of reviewing safe patient handling key drivers, which includes sustained use of the BMAT, safe patient handling injuries, and the goals of the committee. Next slide, Bob. So round one of validation, we developed 2 automated tools in the EHR system that were able to validate the completion of the BMAT by staff. This was done so that we could see if the staff was actually doing it. As you all know, and Corey alluded to, we had alerts firing for the staff, but we know that staff don't always do the alerts that they're given, but they're there for their use. The goal of this first report was a summary report that was a snapshot really of the completion rates of the BMAT by the direct care nurses. When the BMAT was implemented, the form for the documentation was released along with the alerts or reminders to create the fire once a day at the agreed time by the nursing staff. As we know, just because there's the alert, it doesn't mean the assessment is being documented. So we wanted a way to check the compliance rate. The report was sent out monthly to each member of the safe patient handling members at the respective sites so that they could follow up with areas that had low performance and areas for opportunities and for improvement, sort of that Corey had alluded to earlier in some of the specialty areas. This allowed to see the adoption changes of practice over a time. The second report was more of a deeper dive into the BMAT and what we could gain from the BMAT implementation, what levels of BMAT patients we had at each unit and at each hospital level, the change in the BMAT during their stay, because we know as a patient stays, the longer that they have it, you can have it change from either going higher or lower, and we wanted to see where it was. Another special interest was our PT/OT team and rehab team wanted to know, based on their BMAT level, how many consults were being placed for those patients, along with some few other demographic information was obtained. Next slide, Bob. After the first round of auditing of the tool, which was strictly passive through EHR pulling data for us, we decided we kept getting questions and we wanted to look at this in more depth. So we created an audit tool, which was 11 questions done by the members of the system safe patient handling team. And each site was to complete 5 audits per month. So they were a range of people doing them, from our direct care nurses, rehab personnel from OT, PT, our nursing educators, system leaders, senior directors of nursing, and Corey and myself were helping doing these audits, where they would actually visit patients and during their normal days of activities to do another BMAT assessment and compare it with the staff. The questions were, as I said, were comprised of 11 questions, which included some very demographic basic questions: site, unit, the date that the audit was done, what was the most recent BMAT score by the nurse, what was the time frame for that BMAT assessment, what did the auditor score the BMAT as, and if the BMAT score was a level 1, did the patient have BMAT bed rest orders? Is there documentation of ambulation? Is there safe patient handling equipment and supplies at the bedside? Should there be supplies at the bedside? And lastly, we left it comments by the auditor. As you can see, it comes in, we use Microsoft Forms to do it, which comes in a very easily to do it on either a handheld phone or on a desktop computer. Now let's look at the data. Next slide, Bob. The first question we kept getting from people was the BMAT being done correctly by the staff? As you can see, the differences between the nurse and the validator, only 18% of them disagreed with the two scores. So 82% of them were doing it correctly. Bob, next slide. On those 18% that weren't being done, what was the disagreement? Was it a BMAT 1, 2, and 3 or 4? And you can see the majority of them were in between in the BMAT level 1 area. Next slide, Bob. And here you can see where the auditor difference was, whether they rated them up or rated them down. And it was really almost a 50-50 split between those 18% where they disagreed with the audit tool. Next slide, Bob. One question that came up repeatedly in conversation after reviewing the automated reports was, were there a lot of those BMAT patients level 1s, and did they really have BMAT bed rest orders? Even after reviewing all the admission order sets for auto-selecting of bed rest orders, there is not any. The providers had to manually select bed rest. The results of the BMAT demonstrated only 32% of them actually had bed rest orders. So the next question is, where were these patients coming? And we'll see that on the next slide. As you can see, these where they had the bed rest orders were actually in non-ICU or non-critical care areas. Next slide, Bob. The other question that came up anecdotally was, there's no equipment at the bedside. They don't have the slings at the bedside. They don't have them available. So that was why we came up with that question. And all these questions came up with the interdisciplinary team at the system level with these questions from what they were hearing locally at their sites. So as you can see, yes, there was equipment at the bedside where it was appropriately should have equipment. Next slide, Bob. The next question was, is there documentation of ambulation? In the EHR, it's not a yes or no question, but we were able to validate this in the EHR reports and also when the auditors were reporting at as a yes or no, where the staff actually document the length of ambulation. And as you can see, there is an opportunity for improvement in the ambulation and documentation of it, where there's only 66% was not documented of having any ambulation that should have. Next slide, Bob. So the mix of the nurse assessment and ambulation document, it's really where you should see it. And it was in the BMAT 4s and 3s where we had this documentation noted. BMAT 1s, we did not see any ambulation documented, but we did not look at range of motion or passive range of motion by the staff. Next slide. So now, what lessons learned and what's the next steps with this data that we did and continue to do today at MedStar Health? Next slide. So the next question, lessons learned were validate and verify. Always validate and verify the information you hear at meetings. At different meetings with different teams, the reports where the BMAT was not being done completed accurately. And this was not found when the auditors did the subject. As you noted, we had 82% agreement between the auditor and the bedside nurse doing it. We also completed a gap analysis, and we have done that now 3 times and are preparing to do it a 4th time in the next year to see, based on the ANA 8 standards of safe patient handling mobility, to make sure we are actually following those guidelines and using the BMAT appropriately within those guidelines. We also learned that there is now a shared language around the BMAT between our occupational therapists, our physical therapists, respiratory therapists, and other departments. And we also use this during our nursing peer review to give us a better picture of what the patient looks like and when we have specifically falls and pressure injuries. Next slide, Bob. So what's next? We're going to focus areas of improvement based on individual entity data. What does that mean? The data, because it was pulled into forms, we are able to pull out each entity and look at specific areas for opportunities of where there is differences in the auditor's tool, where there's a need for more equipment and supplies, and where the length of stay is based on if they're doing a lot of PT/OT assessments, where they may not necessarily need them for their length of stay discharges. It'll give us a better indication of where our educational needs need to be in all areas with specific focused areas. It also correlates the data we had in prior gap analysis. We will continue doing the audits for continued learning as this was a reasonable sample size, but we know the more audits we get, the better the sample size will be and the better the data will be. We also get to collaborate with nursing informatics to decrease the nursing documentation burden with the BMAT if there's a way we can do it to increase the compliance of all the tools and the ambulation of our patients. Next slide, Bob. And this is how you can reach out to Corey and myself with any additional information you would like. I'm going to turn it back over to you, Bob. Thank you so much.
Donna, Corey, and Teresa, thank you very much. Just a couple of questions that I have as you went through, as well as a couple of things that have come in the chat. And for those on the line, if you would be so kind to enter any questions you have into the chat box, I am monitoring that as we go through the presentation. As you think about accountability and managing the accountability of these results and sharing these results, I know you mentioned you have a safe patient handling team that you look at. It's comprised of rehab and nursing. But broader than that, how do you take this information and kind of share this upstream? You mentioned acquisition of patient handling equipment and defining areas of need, managing falls and pressure injuries. How does the results of the work that you're doing kind of build into the correlation of those other downstream or the impact of those downstream things? And Corey, Donna, jump right in.
Corey, would you like me to take that one?
Sure, I can always add in as needed.
All right, thanks, Bob, for the question. So we do share this information at multiple different committees across the system with our occupational health and safety committees. We share it with our local safety committees and our system level committees. And we also do a year-end report out for leadership. Corey, anything else to add?
Yeah, no, I think for me, it's just kind of connecting back to our evidence-based practice cycle. The performance monitoring and evaluation and performance improvement are really built into that. So, you know, we're really purposeful with our safe patient handling goals at the system level that we cascade down to each local entity. And you know, I think, you know, it's very important, you know, that we have at each of those our interdisciplinary partners so that we understand, you know, where needs are. And, you know, we're always, you know, looking at any educational opportunities and, you know, acquiring new equipment if need be. if there's a particular sling that we're seeing that folks need or can access. And that's been kind of a part of, as we've went away from reusable slings, we've kind of noted we might need some different ones for certain purposes that we need to get for disposable. So that's all I would add.
I'm going to jump in and mention what we did at Banner Health and that I've seen a number of other hospitals do. And again, it's that sharing of information is so critical between making sure that the managers on each unit at this point, it was over 24, 25 hospitals, but making sure that all med-surg units knew that these were evidence-based best practice and was working really well in one hospital, and then making sure to share that and setting expectations around having all the hospitals, all the med-surg units using the same. For the ICUs, making sure that people are aware that in the ICUs where they were using all of their ceiling lifts and repositioning sheets on a consistent basis, their pressure injuries were down and they were no longer having staff injuries, and all patients, including the patients of size, were being boosted and turned on a regular basis, and that was helping with any complications of immobility and having better outcomes. So trying to standardize practice across the entire system really meant communicating all of those success stories, whether it was a small rural hospital in Wyoming where the nurses really figured out this is how the BMAT and the fall risk works together. In this case, it was Morris, but making sure that those best practices, evidence-based best practices that were working for one hospital, for one unit, were shared across the entire system in an effort to standardize as much as possible.
Teresa, thank you for that additional context. We've had a couple of questions, Corey and Donna, regarding the frequency of when you are doing your assessments and then the documentation into the medical record. Could you elaborate further on the frequency of both of those, and then how that information is then reinforced with your staff?
Corey, you want to take that one?
Yeah. So when it comes to, I know there were a couple of questions in the chat. It's not Q shift, it's performed daily. So it's a daily task that fires for the registered nurse. And when it comes to how it's communicated, we've, in a couple of the pilots, we've really focused on bedside resources such as flip books, that are at the bedside to display BMAT level. And just kind of challenging everyone as we think about adopting new technologies. This is something to display on any particular electronic whiteboards and units, as we start to kind of look at those and expand those, that the BMAT level is visible for the associate coming into the room. Yeah, that's all I would add. Thanks.
Corey, just to expand on what Corey said, they do have a task that fires for once a day to do the BMAT score, but they're also to do a BMAT score again when there's any change in condition of the patient. We can't really fire a task on that because you don't necessarily know when there is going to be one. And as Corey said, when we did the pilots, we really focused on flip charts at the bedside. We did really leave that up to our 10 entities to decide how best to display the BMAT level for their patients. Because we try to do a lot of things as a system and systematize everything. But each entity has their own little bit of culture. So we wanted them to allow them to keep their own culture. Some of them would prefer just a one-pager sheet, which the nurses circled to update it. Others like the flip charts. Some liked it at the door, some liked it at the head of the bed. So we really left that up to the entities to decide how they would display the BMAT level. It is also in the EHR where they can all look at it in standard spots for them to look at it. The only difference is our two acute rehab one acute rehab hospital and one acute rehab unit, they do it on admission only because they are really followed by OT-PT on a daily basis and have mobility goals set. So we only wanted it done once on admission then, because a lot of those admissions come in later in the day and are not necessarily seen by PT/OT till the next day or the day after, depending if it was a weekend or anything. So that's the only difference in it is for our acute rehab facilities. Thanks, Bob.
Thank you. That's great. In terms of, and I love the way that you've captured the flexibility of the destination's the same. However, the manner in which you get to that destination can be varied on a site-by-site basis. So, you're measuring the outcome, which is really helpful. Since you began this journey, I'm curious as to, have you seen a reduction in the length of time a person, for example, that is a BMAT 1 or a 2 that should be followed or engaged with therapy, but nursing is leading these assessments. Have you seen, how is that worked? There used to be I'm dating myself, but we need to get a PT consult on Corey before I can get up and get him moving and address falls and such. But nowadays with the BMAT and what you've adopted there, I'm assuming you've compressed that time frame of activity and getting the patients up sooner. Could you elaborate on that for us?
Sure, thanks, Bob. So I'll take this one, Corey, and then you can add on. We have seen some sites where they do their interdisciplinary rounds of care for each patient, actually have the providers ask what is their BMAT level. And based on their BMAT level, may or may not order a PT/OT consult because they're like, is that their baseline? And is there any benefit from ordering a PT/OT consult to have this patient gain any more mobility with a PT/OT consult? We've also seen where they've really used that, as I said earlier in the presentation, that we really don't have a lot of bed rest orders written and auto fire. We have really none. So it is the provider selecting them, but it really does help with them changing them from a bed rest to to activity as tolerated. So our providers are definitely getting involved and asking what their BMAT levels are. Some sites, of course, are better at it than others, but we are seeing the providers asking what a BMAT is, where is the BMAT, how is it, how does this apply to having PT/OT see our patients? Corey, anything to add?
No, just kind of taking it, just putting kind of my spin on it, Donna. I think the BMAT gives us a tool or a foundation to really promote a culture of nurse-led mobility to kind of really combat those, Teresa, as you were saying, those kind of long-standing stigmas of whose role it is to ambulate a patient. So for us, it's focusing on the culture of safe nurse-led mobility. And that's just all I would add. Thanks.
I love that term, safe nurse-led mobility. And that truly is the goal with this as an assessment process, not a screen. So, but thank you. That's helpful. Teresa, we've had a question, an interesting question that does come up from time to time about what prompted the modification and adoption of BMAT 1.0 to 2.0.
A lot of feedback from people using 1.0 and realizing that a number of folks were automatically adjusting the parts of BMAT, the original BMAT, that were confusing. So hearing that, so there were a variety of things that prompted it really being, and that were frankly built into the original BMAT, but maybe weren't communicated as well as they could be, but really trying to address all of the feedback we were getting from people who started adopting it as soon as the first 2 articles written in fall of 2014. People just were jumping on it. And so we knew, the team knew when we created it that there were some things that we had to do an awful lot of explaining around. Why is a person who passed stand but didn't pass step, they're a mobility level 3, a BMAT mobility level 3 patient, but if they pass stand but don't pass step, they're also a mobility level 3. So there was just some confusion around that. There was confusion around how to deal with bed rest, strict bed rest, physiological criteria for doing the BMAT. So really looked at that and took all of that feedback and worked with a number of nurse colleagues and other folks and said, okay, I think we can make this better. And frankly, again, looking at how hospitals had already gone ahead and made some minor modifications to the original BMAT so that it's like what you really have looks like BMAT 2.0. Having said that, there's still a lot of hospitals using the original, and it's working well for them. So that's kind of I've got sent out a document to people who ask for it about why should you stick with the original versus go to 2, and there's some good reasons for doing that. Versus why should you consider 2? 2, frankly, overall is easier to explain. The support tools are very straightforward. It's very linear. It doesn't kind of bounce around between the 3 and the 4, and also address the need for people who have to use a walker, cane, crutches, prosthetics, that we want them to progress also. So that's really that focus on, if you have to use an aid, I still want you to strengthen and progress. And had a number of hospitals, including those with a lot of double amputations, that it's like, I don't want them to be stuck at a mobility level 1 when they can progress. So a variety of reasons. And if anybody's interested in more of why 2, I'm happy to talk to them or send them a couple of response documents that I've written.
Teresa, thank you for explaining that. Just touching on that education for a moment, Donna and Corey, could you elaborate a little further as a caregiver joins your team and starts their orientation and adoption onto a unit-based training module? Well, how do you educate and how do you reinforce the use of the BMAT with your staff, with your leadership, et cetera, to get to the results that you share with us today?
Yeah, do you want me to take this, Donna?
Sure, go ahead, Corey.
And you can just add in. So a couple pieces. When we initially rolled out BMAT across our system, we had the e-learning module, of course, and that was kind of in our initial rollout, our method. But what we've done, and this is it probably differs from site to site within our system. So I'll just kind of speak to what my organization is doing. When a new member comes onto our team, we have it built into their orientation sessions so that they actually get hands-on with each piece of equipment. And so we kind of pull those down to our central education area and go through a competency list for each piece of equipment so that they know how to use it. We're still working on just-in-time resources. We have QR codes that we're placing on all the equipment that link to manufacturer videos. And something our Safe Patient Handling and Falls Committee has been working on at Montgomery is kind of a master chart that's just in time to say, how you're going to mobilize the patient if you need to do a sit to stand or a flat sheet that kind of guides you through which piece of equipment to use, and is kind of a nice just-in-time resource for staff. And when it comes to BMAT assessment, it's walking through the e-learning module. Anything to add, Donna?
No, Corey, I think you did a great job of there. And really, the education part is not all nursing. Many of our sites, it's a partnership between Safe Patient Handling Mobility Committee, occupational therapy and rehab therapy, and nursing, and they do it as a combination together. So you get all the expertise doing the training on both the BMAT and the equipment that they're using and how to mobilize their patients safely. The only other thing I would add, Corey, is we did really do 2 e-learning, and I saw this question pop up in the chat a little bit too, is why 2 different ones? And the shared language. it really goes back to the shared language, why we did two. We did a licensed and unlicensed. And really, those were just only titles that we could come up with because we wanted one that OT, PT, and nursing could do, even though nursing was doing the assessment. We really wanted it to be more technical for people that are licensed to understand the BMAT and the BMAT categories. And the unlicensed ones were really for our nursing aid, our transporters, our radiology techs, so that they could have that shared language. And then they came down and saw a patient had a BMAT level 2 on their ticket to ride that a lot of entities use and a lot of systems use to transport, to communicate between departments. They would know what that meant and what equipment they needed, how to mobilize the patient safely for both the associate and the patient. So that's why we really came out with 2 different e-learning modules, was so that we could have that shared language and people would know what it meant. We gave and of course they could see either one. It's not locked down based on your credentials or anything like that. They could see it. We gave options to people to use whichever one they felt was more appropriate for your staff. And we gave that option to the providers too.
I love.
Oh, go ahead. Sorry, Bob.
No, Teresa, go ahead, please.
I was going to say that's basically the same thing that we did at Banner. We had a variety of learning tools that were for transporters, radiology techs versus the RNs, the CNAs, OTPT. So recognize that the common language became really critical, and that became a real satisfier that staff were saying, yeah, we're speaking a common language. We have a better understanding of what precautions we need to take and what SPHM equipment we need to use consistently.
And I think that's so important. When we look at the nature of events of harm to patients, often we can correlate that to a lack of a handoff and an understanding. So that communication and that common language amongst all caregivers, licensed and unlicensed, I think is a very important takeaway for all of us today, that is that handoff. Do you do bedside shift change and communication tool there at MedStar Health?
We do. Is it consistently done? Not necessarily, but we do encourage our staff to do it. And a lot of the staff do it and find it very helpful for both our patients and the staff so that they can see the patient and really to ask questions. Because as we said, we only do the BMAT once a day. So you may come in later in the day, as Teresa said, and their BMAT may have gone up or may have gone down for the amount of activity they've done during the day. So you can always do another BMAT while you're there and having the shared language. We also encourage our nursing associates, techs, and if they have a question and they're like, this doesn't really match the picture I have in my mind of what a BMAT level 2 is, they're encouraged to go ask the nursing staff to reassess.
That's great.
Corey, anything to add?
No, I would just add the importance of, anywhere we have electronic report sheets and, BMAT, is included, and that it looks very different site to site, but yeah.
There's a question back to training. Do you use a competency-based model when you're doing the training to assure? Great, I see your head shakes. I know that during COVID, we were sometimes forced to just go with computer-based training modules. It's really tough to assess that competency. And I assume you've moved more to a hands-on model post-COVID?
We still do both, Bob, and really built into the electronic electronic training module isn't actually a patient assessment. Corey, it's been a couple of years since I've taken it, but I believe that there's even more than one patient to assess in it. So they have the competency base, and then there's also competency-based assessments for the safe patient handling equipment itself. But we do build it into the e-learning modules too, and some of the sites still are also doing hands-on. Corey, anything to add?
No, Donna, that's great.
A question is in the chat. We didn't touch on this directly today, but I'll just, emphasize that there is a question about any data using the BMAT with mobilizing intubated patients. Teresa, have you done any work in that space?
I'm aware of SPHM equipment used to mobilize intubated patients. The first time I showed it to a group of nurses and doctors, had a little video clip that I got from one of the manufacturers or from, a vendor rep. there was a gasp. It's like, whoa. And we talked about why they started off a mobility level 1, but then they were actually able, along with the use of SPHM equipment, to be up and walking. So, and that was a number of years ago. So I'm not sure of anybody doing any actual research around that or a quality improvement. I do know of ICUs that are aware that, we need to get our intubated patients, our ECMO patients up and walking. And if you use the right equipment and again, do a brief mobility assessment, it's absolutely doable. You typically need more staff to make sure that everybody's playing their part and that the patient is safe. But yeah.
Okay, thank you. I'm going to forward these slides just to go to the evaluation for those online. If you will scan this QR symbol for the evaluation process in our remaining time, I'd be grateful. A question that came up around permission to use the tool. I did not touch on this in the presentation earlier today, but the licensor of a no-fee agreement is through Baxter, and I would serve as your point of contact should you have a desire to find out more about the BMAT, look at the resources that are there for the BMAT itself. I would be your point of contact for anything related to permission of use. And this permission is granted. Sometimes I receive 2 or 3 requests a week for this work. And as you heard Donna and Corey mention, they built this into their capstone work of as they went to their DNP. So a lot of different applications. As you look at the work that you've done, the slide that you showed with the reduction in safe patient mobilization injuries was dramatic and great outcomes. Have you seen anything in the space of patient fall reduction? And even a little further, I'll take it, and that's in terms of mobilizing patients to reduce pressure injuries. Any data you've found there at MedStar Health in those 2 areas?
No, we have not found any data related to those 2 areas at this time. It is something that we keep watching and looking for. If anybody has the magic bullet on how to prevent falls of patients, I think everybody would be in on this call would be interested in knowing that. Corey, anything else to add?
No, we did really focused. We did really focused work in the pilots, which one of them was my DMP project and the other was Donna's. We did a lot of focus work there, and mine specifically looked at falls. And we do use the Morris Falls scale. So we looked at a number of things, but between using both tools and layering in mobility assessment, there's some evidence out there that really kind of points to taking a look at fall risk and mobility assessment as kind of the big picture. So that's where we went with my project. The time frame that we implement these, looking very focused at outcomes, there really wasn't a significant impact on fall rates. But real limitation there is time, and of course, very multifactorial when we look at it across our large system.
Thank you.
At Banner for the pilot project, that was a big driver that we saw a significant decrease in falls with consistent use of the BMAT and consistent use of SPHM equipment. And it was one of the reasons that the nurses really got on board and they started presenting their findings at a number of national nurse research conferences, but it's hard to come by. And then when we did the BMAT validation project at Banner Baywood, same thing. They saw a decrease in falls that they absolutely attributed to using the BMAT and using SPHM equipment consistently. One of the other projects we did that really never got written up was we looked at how the Morris was built in the EMR and worked with a number of people and improved that and connected the BMAT and the Morris Fall scale. But I've heard a lot of anecdotal information. I would love to see a full-blown project. Again, it's hard to do. It's hard to get that falls data and to make sure that it's accurate, that all falls have actually been reported. What I do hear from nurses is by being more aware of orthostatic hypotension, syncope, and being more cautious in using SPHM equipment and being more aware of the patient's BMAT status, they will state that they feel, that has contributed to a decrease in falls. But yeah, no, not as much hard data around falls and BMAT and SPHM as we'd all like.
So that's a challenge for all of us participating in today's webinar, that the looking at falls, pressure injury reduction, and in the last couple of remarks around decreasing length of stay, I think that is fertile ground. So again, future opportunities for us to present as we go into 2025 on taking the information we built today as foundational and then looking at how it's going to impact fall reduction and pressure injury reduction. I will just one more plug for the screenshot that you see at the present time. Please take a moment, scan that QR symbol, give us your feedback. That allows us to drive future presentations that you would find of value and interest as we go forward. Is in the remaining time, we're at the top of the hour. I just want to take the moment to thank Teresa, Donna, and Corey for their time, talent, and effort putting today's presentation together. Great lessons learned, great opportunity that can be shared in any health system. So this is wonderfully transportable for that space. So I want to thank them for their time. I want to thank you for joining today. Wish everyone a safe, happy holidays and a good rest of your week. And with that, I'll bid a fond adieu and enjoy the rest of your day. Thank you.